Hello, Dr. Felix.
Hi, how are you? Tell me, I cannot start my video.
No worries. I can't wait to see your face.
Oh, because you're managing it. All right.
Okay. Can you turn on your video or do you need me to do it for you?
Let's see. I think you need to do it for me.
Okay, let's see. Mm, Okay. Did that work? Can you do it now?
Hold on.
Okay, you should be able to do it now.
Let's see. Yep.
Yay!
Oh my God.
Wonderful.
Oh,
How-
wonderful.
Nice to meet you. Well, nice to
It is a
introduce.
pleasure to be seen by you.
Yes, you as well. You as well. Alrighty, so we're gonna go ahead and jump right into today's session, okay?
Okay, very good.
Wonderful. So thank you, everyone, for coming back to our Maternal and Child Health Speaker Series. I'm excited to introduce and welcome our guest speaker today. And so I just want to let you guys know as a reminder, you are able to raise your hand and ask questions as well, but also feel free to drop them in the chat. I'll be monitoring them, and then I can also bring them to Dr. Felix's attention as well throughout the session today. So again, I just want to thank you all for being here, and I will get right started by introducing our wonderful panelist. Alrighty, so Dr. Felix self-identifies as a spiritual activist who has pursued health justice in a myriad of professional roles. She's trained in medicine, health services, and community-based participatory research and generative leadership coaching. She joined the Johns Hopkins Bloomberg School of Public Health in January 2023 as a distinguished scholar in the Department of Health and Management. Her research highlights solutions to systemic racism. She currently leads the Black Birthing Future Study, which is an in-depth asset-based narrative study on how Black midwives are addressing the Black perinatal crisis in the United States. Her teaching focuses on helping leaders to develop their leadership capabilities to address complex social arrangements such as racism, climate change, and poverty. Prior to joining Johns Hopkins, she's had a 23-year career advancing minority health, health disparities, racial equity, and racial justice at the Agency for Healthcare Research and Quality, Health Resources and Service Administration, at the Robert Wood Johnson Foundation. So thank you all for helping me welcome Dr. Felix, and I cannot wait to hear your presentation today.
Oh, thank you. Thank you so very much. It's a really wonderful pleasure for me to be here meeting with you guys. I really want to express my appreciation to Dr. Baptiste Roberts for extending this invitation to me. She's asked me, and I said, of course. Yeah, so and I have to tell you, the favorite part of the presentation for me, it's going to be the question and answer. So I have a few slides that I'm going to be sharing with you. But as we know, there is so much expertise and so much wisdom in the audience that I'm really looking forward to the next part. So let me share. Will I be sharing my slides or you'll be sharing my slides?
Yes, you can share your slides. Let me know if you have access to do that, Dr. Felix.
I Oh, brilliant. I do. Can you see my slides?
Not as of yet. I think,
Okay, all right, very good. So let me share.
okay,
That's
wonderful.
one.
I'll let you know when we can see them.
Hold on. Okay, I need to escape. I need to get back into Zoom. And I need to press share. That's it. All right, so let's get here. All right.
Perfect. And so you're sharing your screen, so whenever you're ready, we can see your slide.
Right, right. Okay, so the title of my talk is Black Birthing Futures, Elevating Voices from the Community. So we know the state of Black maternal health in the United States. We've heard all the statistics. Um, We know that Black and Indigenous women experience higher rates of pregnancy-related death, illness, and complications. But we also know that there is a growing movement within the Black community to increase community birth so that we can address this crisis. So in 2023, we started with a question. We, like you, had heard of the statistics, but we weren't hearing a lot about what Black communities were doing. So my team and I engaged with about 58 experts in the field, and we asked this very simple question. What is the Black community doing to address the Black maternal health crisis? And we heard three big themes. One, which was the overemphasis on negative mortality and morbidity statistics is harmful. And people felt really strongly about that. They thought that in the mainstream, there was a kind of admiration for the problem and really a kind of sidelining or minimizing what communities were doing. The second thing we heard is that centering the voices and investments that frontline workers and Black leaders were doing, especially women, that was just. And that it was important to look at the work of Black women. And the third thing we heard, which I was surprised about, to be honest with you, was that Black community midwives are important, very important, yet under-resourced strategy to addressing the Black maternal health crisis. So that led us to really think deeply about Black community midwives, who they were and what were they doing in communities. We got really curious. So let me tell you a little bit about midwives in the United States. There are two big categories of midwives. There's what is called community midwives or direct entry midwives, and there are nurse midwives. Direct entry or community midwives are trained in communities. They're educated, they're trained, but outside the medical establishment. They are credentialed often as what is called certified professional midwives or CPMs. They overwhelmingly practice in communities, either at home or in birth centers. And they are licensed to practice in 38 states. So, you may be living in a state where they practice, where they're licensed, or they're not. Nurse midwives, on the other hand, are trained in hospitals. So you have to be a nurse first, and then you go and you are trained as a nurse midwife. Mostly, that's not always the case. They're credentialed as certified nurse midwives. They're primarily in hospitals, and they're licensed to practice in all 50 states. However, sometimes for the nurse to practice, they need to be supervised by a physician. So here are the research aims. We were really interested. Again, we learned from the community that community midwives was an important strategy to addressing the Black maternal health crisis. So we designed a study that really would really explore what was happening in that space. We had three specific aims. What were the unique aspects to the care that Black community midwives provide to community people? To Black birthing people in community settings. So that was the first aim. The second aim was to identify the environmental conditions that support and hinder that practice, right? So if these people are in the community, doing work that addresses the Black maternal health crisis, what's helping them? What's hindering them? We were interested in that. The third was to describe the impact of their practice on birthing people, families, and communities. So was it making a difference? And if so, what kind of difference was it making? So these are our research questions. We had a number of research questions, about 8 research questions, and I want us to focus. I'll only be focusing on 2 of those questions because they are, let me just go back to the other slide. They are related to the findings that I will be presenting. So today, in my talk to you, I'm going to be talking about the unique aspects of care that Black midwives provide and their impact. And so the 2 research questions we will explore today are, how does the care provided by Black midwives in community setting impact their clients? And what unique approaches do Black midwives employ in caring for Black clients? And how do these approaches benefit these clients, right? So if we say that that is an under-resourced and important strategy, what are they doing really? And why do we think it makes a difference? So here's what we did. We designed an asset-based narrative case study of Black community midwives. And I'll go into details about what it is we did, why we call it asset-based, why we call it narrative. So it's asset-based because we're looking at the solutions. We're not rehashing the problems. We're actually looking at the solutions that is within the Black community itself and how it's addressing those challenges. It's a narrative case study because we're looking at what we are drawing on people's stories. We're interviewing them. We're asking them to tell us their stories. So our research is story rich, narrative rich. And it's a case study because we are doing what we call a 360 around these midwives. So we are looking, we've identified this community midwife and we're looking at the care that the midwife provides, but we're not just asking the midwife about the care that she or they provide. We're asking the client about their experience with care. We're asking the midwives' colleagues, meaning their collaborators, about that experience, the client's families. So we're really doing a 360 around the kind of care that these midwives provide. So it's really in depth. There are three types of data collection we engaged in. Interviews, as I said, with the case midwife, and we also interviewed the people around the midwife. But again, all of these questions have to do with the midwifery, with the community midwifery care that the midwife provides to Black mothers. That's one. The second source of data was the midwife client observation, meaning I, as the researcher, went in to observe. I shadowed the midwives, and generally I spent about 7 hours gathering data on every midwife, every case that was enrolled in the study, observing the midwife, sitting quietly in the corner, looking and listening and observing how the midwife was interacting with the clients. And then the third kind of data we collected was survey data. We surveyed the midwives' clients, meaning the Black midwives' clients, on the care that the midwife provided. So not only did this client talk about, well, not only did they speak about the care that they received, not only did we ask them open-ended, semi-structured interview questions to describe the care, we asked them pointed questions. We asked them to evaluate the care in terms of respect. We asked them to evaluate the care in terms of decision making, their ability to make decisions. And we also asked them to evaluate the care in terms of their autonomy. And we chose these areas because research has shown that these are three dimensions of care that are especially important for maternity care. All right. So who got into our study, right? The cases, right? We got cases. So the case midwives had to identify as Black or African American. They had to be currently practicing in the United States. So if you were outside the United States, we were happy you were doing this work, you were not eligible for our study. They had to have a current license or to be certified as a midwife or to be recognized as a traditional midwife. And that is to be inclusive of all the different avenues that Black midwives engage in terms of coming into the field. They had to practice midwifery for at least 5 years. And we did that because we wanted people who were really experienced. We didn't want people coming right out of school and really trying to establish themselves. To be eligible for our study, 40% of your clients had to be Black. So you could see other clients, but we wanted people with expertise, but not only people with expertise in that area, people who were actually committed to that area and doing service in that area. And the last criteria we had, at least 50% of your deliveries had to occur in the home or in a birth center. So here are our cases. We had one case in a northeastern state. The second case was in a southern state. The third was in a midwestern state. The fourth in a western state. And then the fifth was in a Pacific Western state. And we also had supplemental interviews. So we had a total of 57 people that we interviewed. And the supplemental interviews were people we met. We weren't really looking for them, But when we discovered them in the course of doing the data, they had such compelling, I mean, their work was important to community midwifery. So although they weren't a case, their work was important to community, to Black community midwifery, like that we included them. So here are the midwives that were included in our study. You already know that we had 5 case midwives, right? So we had 5 case midwives. Both direct community midwives and nurse midwives were eligible. As it turns out, all the midwives in our study were community midwives, direct entry midwives. Of the collaborating providers, meaning providers who are also working with these case midwives to provide care for their clients, 3 of them were also community midwives. 3 of the community midwives, there were an additional 3 community midwives, which were community stakeholders. Remember, we did that 360 around these midwives. So a community stakeholder was somebody who was in the community that the midwife worked in. And while they did not like collaborate with the midwife to provide services, their work influenced the work of the midwife. So let me give you an example. One example is, for example, a birth fund. There are many, I don't know how many there are, but there are several cities in the United States where there's what is called a birth fund. And a birth fund is a philanthropic effort, like a little fund to help Black women and other people afford a home birth or afford a birth center birth, right? So a community stakeholder, one of the community stakeholders were these birth fund organizations. And there were also family members who were midwives. So in total, we had 11 certified professional midwives and 2 nurse midwives in all. Most of the midwives in our study the overwhelming majority were Black. There was only 1 white midwife. So here are the participants. Of the 57 participants, we included in our study, we enrolled, who participated in our study. The majority of them were under 40. 26 of them were under 30, and 13 were between 31 and 40. The majority, 41, identified as Black or African American. Regarding marital status, most of them were married. Most of them, the overwhelming majority, again, identified as women. There was 1 person who identified as non-binary or gender queer. Regarding sexual orientation, 47 out of 57 identified as straight. And I think the interesting thing about spirituality here is that only 10 out of 47 did not identify with any kind of spiritual or religious tradition. So now I'm going to be sharing with you some of the preliminary findings in our study. So here's what I'm going to share with you about what from reports, what do community midwives do? So community midwives provide medical care related to pregnancy. So they're taking blood pressure. They're sending people for urine test. They are doing glucose testing, right? So they're doing all the things you expect on the medical front. They are definitely doing that. And they're also doing in-depth counseling related to pregnancy, wellness, and improvement, right? So they're doing a lot of education on nutrition, on diet, on physical movement, right? They're providing a lot of support for people. So they're educating the family, educating the woman on what it means to be pregnant, on what it means to prepare her or their body to have a baby. The other thing that from these interviews, we learned that midwives do a lot of family education as well as integration. So they're not only educating the client, they're educating the family. So if the grandma, right, the woman's mother is there at the prenatal visit, the midwife integrates her into the visit. And one of the things that was most remarkable was how the midwife, clients reporting that the midwife not only educated them, but also educated their husbands. And that was a big, or their male partners. So there's a lot of family education and integration and giving the family members specific roles to play in the pregnancy, in the labor, and in the postpartum period. Midwives also conducted comprehensive and frequent postpartum care. They did a lot of client advocacy within the hospital, really helping clients navigate the hospital system, helping clients prepare for that visit with the obstetrician. Okay, what questions should you ask when the client comes back from the obstetrician and they have a million questions because there was no opportunity to address their questions, or they were afraid to ask questions? These midwives would be, sitting with the clients and really taking apart and really helping the clients understand what their doctors actually were saying. They also provided local community education. I don't know if some of you guys have heard of what is called community baby showers, right? Which is a community event around birth. They also provided social networking opportunities for birthing people and their family members. Thank you. All right. Hold on, let's see this. Okay. The other thing we observed that midwives did was that there was a role they played in the community. Um, they not only functioned with their clients, but they also supported the healing and empowerment of families, including the client, as well as the community. And they talked a lot about honoring their ancestral legacy. So the midwives in this study were very much connected um, with the midwives of the past. And as you know, I mean, you may or may not know that midwifery was a big tradition in the Americas, especially in the South, as well as in the Caribbean, like in Black communities. And that midwife had very honored roles in these communities. And that was the case until the late 1800s, late 1800s, early 1900s, when through the action of physician institutions, individual physicians, as well as physicians institutions, like the American Medical Association, through a process of disinformation and misinformation, midwives were marginalized, described as uneducated and dirty, and birthing was taken out of the community and put into hospitals. In our study, we also learned that midwives functioned very much as community builders. They facilitated parent support groups. They provided gathering spaces, not just for pregnant people, but for the wider community. And in one case, which I thought was so powerful, a midwife had a storefront in a city in the Northwest, and it was a community space. It was a gathering spaces, again, not just for pregnant people, but for the wider community. And out of these gathering spaces, a bookstore, a community bookstore emerged. And that bookstore is still open today, which I think is just a phenomenal story. So we just talked about what midwives reported, like what we learned from the reports and from the interviews. Let me just share with you what I observed from, I mean, this is preliminary, what I observed from these observations. And we had about 14 observations, right? For every midwife, anywhere for 10 hours of observations. They spent about an hour to 2 hours with their clients. I'm going to repeat that, an hour to 2 hours with their clients. And clients told us at a minimum, midwives spent 30 minutes with them. These visits were conducted in homes and in a birth center. They spent a significant amount of time educating clients. I think the visits that I observed, I think at least 30% was educating. Just a lot of, and when I'm talking educate, I'm not talking about lecturing. I just want us to be clear. We're talking about a conversation between people. And so the midwife would open the visit with asking the client, do you have any questions? And for the first 15 minutes is just the client emptying themselves out, asking their questions. And this is done in a very back and forth, informal. Sometimes it's more structured than others, but it's always highly personal. What I noticed is that they positively engaged the fathers and the children present. So they were always bending down, talking to the child. If there was a toddler with the mother, they would talk to the toddler, bend down, engage the toddler, their father. They were really concerned what's happening. How is the family doing with this new child? Really thinking about, okay, how do we stabilize this family having a child? It's a big event. I think it's a big event. It's a big contribution when you may have a child. It's a huge contribution that you're making to society. It's a big deal to bring a child into the world, and it can have, consequences in terms of the family dynamic. It can be a very stressful experience. So they're checking on how is the family doing? Is the family getting, enough support? Dad, how are you doing? How is your business? How is work? These are the kinds of conversations like I observe these midwives doing. For example, one midwife said to a father at the end of the visit, so how's your business going? She said, like, things are cool. I'm doing good. She says to him, I have a platform here. If you need support with your business, we'd be happy to help you. And I was just like, wow. And that kind of engagement took different forms. Not everybody had a platform. So some would engage fathers, would direct their fathers, would get mentors for the fathers, or peer groups, right? Dad support groups, right? All different kinds of ways. There was a kind of positive engagement. I also observed midwives reaching out in real time to provide to other providers and social service agencies for their clients. So, for example, one midwife, and I think that's really important, where you have things like domestic violence. There was one case where a client, after the group visit, she came into the midwife and says, I'm ready to leave. I want to leave. This is too much. And the midwife just got on the phone, called, got the forms for her to get emergency housing. But emergency housing is a week later, like 48, 72 hours later. So she called up somebody in her network and say, hey, this person needs a place to stay. It was like, yep, she can stay at my house. I'm not staying at my house. I'm living with my partner. She can have my apartment for the next several days. Like, that's what I observed, right? And that is important when we talk about a strategy to address the crisis, because we know or we're learning that, a big cause, a significant cause for maternal death in the postpartum period is violence, is domestic violence, right? And so these are the pathways by which midwives, caring, Black clients being served by community midwives, these are the pathways, these are the protective factors for preserving Black women's lives. They also centered socio-emotional and spiritual support for the birthing person, as I described. All right. So here's what these midwives valued: patient autonomy and informed decision making, patient safety. That's something that came up over and over again. This focus on patient safety, deep caring for Black mothers and birthing people. That's huge, and we'll illustrate that in a bit. Community service was another value of them, and spirituality. And I want to lift up the issue around patient safety. That the patient safety we're describing here is not just you're concerned if somebody is hemorrhaging. Of course, you have to be concerned for that hemorrhage, but it's not just about hemorrhaging. What I learned is that these midwives cared for the physical safety, like hemorrhage, but also for the emotional safety of women and their birthing people. So let me give you an example of that. So a midwife is working out west with her client, and they are planning a community birth in the home. And the client is very excited about the birth. It's her first child. Her mother is coming out. Her mother is coming from either Alabama or Mississippi, someplace, or one of the states in the South. And when she arrives, her daughter does not tell her that she's having a home birth. So when she arrives in the Pacific, out west, she learns that her daughter is having a home birth, and she is very upset about it and does not want the daughter, is completely opposed to it. And now she starts fighting with the daughter. And the midwife, observing that or hearing about that, assesses that the client is no longer safe for her to birth in the home. With that much stress in the house, with the fighting in the home, it's no longer safe for her to have birth. So she recommends to the mom that they need to move to the hospital. So the mother moves into the hospital, and the midwife moves with the mother as her doula. So in the community, she's the primary provider, but in the hospital, she's the support person. And she did this because of her understanding of safety and her understanding of what is needed for pregnancy. These midwives are experts in pregnancy. I want to say that again. The people that I interviewed were experts in pregnancy. And somebody said something to me that I hadn't really thought about. And they said to me, when we look at nature, there are a lot of cues we can get, and there's a lot of medicine in nature. So when you look at nature, when you look at animals, right, what they do is when they're ready to give birth, they go away in a quiet place and they have birth. They're not having birth in a stressful environment. Stress is a poison for birth and pregnancy. I'm going to say it again. Stress, and the kind of stress, right, we experience sometimes, is a poison for pregnancy. And so midwives understand that, and they do everything in their power to create an environment for the person giving birth to be relaxed, to be comfortable, right? So know we have birth plans, right? And people have birth plans, and initially people would ridicule that. No, we understand that that is important. It's not somebody just being arbitrary, but what is the environment they want to create for themselves so that they can have the best experience and deliver their baby. So here is what clients told us, how they experience midwife's care, right? So initially we talked about the clients, but now we're going to be talking about how they, what their experience of care is. They deeply valued community midwifery care for the spiritual, emotional, and education support. They appreciated shared decision-making and inclusion of their families. And I have to tell you, interview after interview after interview talked about that. And they sometimes juxtaposed that and compared that with the disrespect that they or their partners received in mainstream hospital settings. So that was like a juxtaposition for them. They valued hospital care, however, right? People had a critique of hospital care. They valued hospital care, however, but when it was necessary. When it was necessary. And here's an example of the value that a client is saying about how she was cared for in a holistic way. And let me just give you some background. So this woman is a nurse. She's somebody who works in the hospital, and she wanted a home birth after 2 or 3 births in the hospital. She was up to her eyeballs with it, and she was not going to have it. She was contemplating an unassisted birth. I don't know if you guys have heard of free births where people just have their children, but somebody told her, don't. Here's a midwife. These are experts in birth. Call a midwife. So she worked with a midwife, and she had a beautiful birth at home. Amazing birth. However, after the delivery, so as an aside, there are two when somebody has a child vaginally, there are two things that happen. There are two births. The first birth is the birth of the baby. And then the second birth, I didn't know that, I learned that, so I'm sharing with you something I learned, is the birth of the placenta. So the baby was born brilliantly, beautiful, just magical. The placenta birth, not happening. So the midwife sprung into action, and the client had to be rushed to the hospital. So she doesn't take her baby, she leaves her newborn in the home with the father and the rest of the birthing team. So here's what the client says about the team of people who she lives in the house with the newborn father, with the newborn and the newborn's father and the other children. She said, they did our laundry. They washed our dishes. She gave my baby her first bath and recorded it and sent it to me. Her birthing student was also breastfeeding at that time. And because I was away from the baby for so long, the birthing student breastfed my baby for the first time. It's just things that you'd never experience if you were in any other situation. And if you were in any other setting. And that was powerful to me, that they cared that much to make sure that they looked after us in that way. As I was saying earlier on, regarding the experience of care, the clients perceive midwives as experts in pregnancy. And they are experts. I'm a physician, and what I observed, they are definitely experts in pregnancy and in a normal, healthy pregnancy. And many of the clients we interviewed had 2 and 4 pregnancies under community midwifery care. So these were not people who, these were people who took it very, very seriously. Clients also had some significant barriers when they experienced midwifery care. High out-of-pocket costs, anywhere from $5.5 to $8,000 out of pocket, right? If they had gone to a hospital, the hospital probably would have charged their insurance charged them $18,000, the insurance would have covered it. People experience a lot of family resistance to having a community birth. Families, like I told you, like I described, thinking it's unsafe or that it's outdated. And they also experience a lot of mistreatment upon transferring to hospital care. And here's a client talking about how the inaffordability of community midwifery. I was disappointed in the fact that's not something that's more accessible, right? I'm not sure if it's just my insurance or if it's insurance in general, but I recognize that's a major disparity, meaning that insurance pays for hospital care but does not pay for community midwifery care. So here are quotes that capture the impact of midwifery care. I think that's one of the last slides. We're getting to the end. And I'm going to read each one going from left to right. I think my care impacted our overall community greatly because we have grandparents who are still alive and who don't agree with home birth and don't agree with assisted birth outside of the hospital, who didn't have the information that we had or that were privy to and had access to during this process. That changed a lot throughout our generation. And I think just in general, it's kind of opened up a door by us being brave enough to go through it and to trust the process. And what they're talking here is now about their family. this couple going through that community birth, not only is it will influence generations moving forward, but their grandparents who were opposed to midwifery and are now supportive of community midwifery. In the second quote is the quote that starts, "My husband didn't know what to expect. I don't think a lot of men know what to expect when entering into a patient agreement like a home birth. I think he was a little afraid initially, and I think she impacted him more than she impacted me. She made him feel empowered as a Black father by involving him in our visits, by allowing him to participate and be acknowledged, and just overall a part of what was going on." Then the other is, and I'll end with the one all the way to the right. "Midwifery," she's talking about her, "made us hopeful again. It made us say if we should ever decide to continue trying for children or to end up in a situation where we're having another child, we have options. We don't have to experience the type of fear or the type of out of pocket, sorry, or the type of off-put that we experience in the environments that we're used to." And here she's talking about options. And I think for Black people and Black birthing people, options and having options is so important. It's tied to our dignity, it's tied to our humanity. And then the last quote, which was my favorite of all quotes, because it shows so much generosity. And I think for me, I'm kind of editorializing before I share this quote, is that when people have deep and meaningful experiences, they want to share it with others. And so this birthing woman says, "I wish I could have experienced every birth that way," right? But she didn't. Then she goes on to say, "I wish that every woman who wished to experience that could experience it the way that I did." So in summary, Black community midwives, that's a typo here. Black community midwife experience engage Black community midwives' engagement with their clients went beyond the provision of medical services to including and focusing on client and families' education, support, and well-being. Clients valued the holistic care that midwives provided to them and their families, including their male partners. The recommendations that come out of that is increase knowledge about community midwifery, and that's what I'm committed to doing, and shift the mindset about community midwifery. Increase affordability and availability of community midwives. So the number, availability, and affordability, like the price point and insurance coverage. And the last is to better integrate community and hospital birth for Black clients who transfer into care. So now I've done my part, now it's your part, and I'd like us to frame our conversation with these 5 questions, some guiding questions, just to frame, these are just framing questions. What resonates with you? What surprised you? What do you think is missing? What would you like to know more about? And how would you like to be involved? So I'm going to stop sharing my, yeah.
Wonderful. Thank you so much, Dr. Felix, for that amazing presentation. And I'm wondering if you might be able to keep that last slide up just so that people that are
Okay, all right. Yeah, let's see.
just see your discussion
Is there
questions.
a chat at all? No.
Yes, there's a chat. You can drop
So
those
I
questions.
can put it in the chat. Let me put it in the chat. Okay, give me a minute.
No worries, take your time. And while you do that, we do have one participant raising their hand, Nevaeh. If
Can you guys hear me? Sorry, I didn't see my mute button how I normally do.
You're all good. We can hear you, Nevaeh.
Okay. I just want to say first, thank you for that. That was really informative. And I just love being a part of anything that allows me to gain more knowledge. So I really appreciate your presentation. What resonated with me is, so I'm currently a doula, and I've gotten the opportunity through Morgan as well. And Initially, when I started my journey at Morgan, I was a biology pre-med major looking to become a doctor, specifically an OBGYN.
Yeah.
But then I took a course for public health at Morgan, and it completely changed the trajectory of where I wanted to go, because then I realized that there were other ways to serve moms and babies than becoming a medical doctor.
Yeah.
So I kind of just fell in love with all things public health. And again, in addition to being a part of that doula program that I was doing at the time, it just kind of everything just flowed really well together. So now I have the desire to be a midwife instead.
Mhm.
Um, so for me, really just what I want to understand a little bit more is knowing and understanding whether a CPM route is better or a CNM, and not better in the way of like, that's pretty subjective, but just because I know there's certain there's different pathways to actually getting there. I know with a CNM, you have to be a registered nurse first.
Yeah.
Um, but I feel like for me, with the CPM route, it's kind of harder for me to understand. So
Yeah, yes. Okay, that's a really good question. So first, I think I'm just so happy that there are people like you who are pre-med and we're like, oh, if what's driving me is serving my community, maybe becoming an OBGYN is not what I want to do. And maybe some do. Maybe that is the path. But having more options, I didn't have that option when I was your age. So I'll ask you I'll answer that question by asking you your question, which is where do you wanna serve? Do you want to be in the community or you want to be in hospitals? Because part of why I chose the community for their personal reasons, but I believe that there's how do I say this diplomatically? I believe that we need hospitals, but I was especially interested in people whose imagination was not going to be constrained by what's in hospitals. I wanted people who were the walkouts, who were tired of the system and its constraints and have kind of like thrown off the kind of shackles to be in these large institutions imposed on us. And some of it is necessary, but a lot of it is outmoded, but we're still doing it. It no longer serves, but we're still doing. So I was interested in those kind of people who were in the community. And so I remember a very good friend of mine saying to me, but why aren't you going to study in the hospital? That's where the problem is. I'm like, yeah, that's why I'm not going there. I'm committed to the solution. And so I want to say, if you want to be in communities, if you want to be taking care of women in their homes, which I mean, I didn't even know that was possible to have your birth, but now I know, and it is. I mean, yeah, it is. It's really important. Or in a birth center, I would say do the CPM. Um, there are, they are credentialed. It seems like credentialing is important to you, so you would want to do that. Um, and I think there's some accredited schools. So you and I can have more of a conversation. But I think what I would use to guide me is, where do you want to serve? And do you want to be building something? Because I think what the CPM, these communities are doing is building something that I believe that will take us into the future.
thank you for that. That was a good insight.
Thank you, Nevaeh. Dr. Felix, we have three more questions for you, so I'm going to go in order. So we have a question from Dr. Baptiste Roberts asking, she'd like to know about birthing persons who did not have family support.
Yeah. Yeah. I mean, there were people who did not have a lot of family support, and the midwives were really good at sussing that out and getting them connected. I remember the one client I saw, it was just her Not a lot of support. I mean, her husband was trying his best, but she had a small child and parents were in other states, and it was just hard. And, the midwives take steps to connect these people to families, or sometimes there's abuse in the relationship. So we're not talking about, um, people whose families are perfect. That is not, I mean, that is beyond the case. And I think in some settings you have group visits where the community now becomes the family. So not the family of origin, but the family of choice.
Thank you, Dr. Felix. So the next question is coming from Mikana. I see that your hand is up. Are you able to speak, Mikana? I think you are.
Yes, I had to wait for the unmute thing. I've never done that before. That was so cool.
Wesley, can you turn on your camera, McKnight? I'd love to see another face, including Zaire has a beautiful face, but I'd love to see another face.
Can you see me?
Not yet, but that's cool.
Okay. I don't have access to the camera.
That's fine.
Okay. Sorry. I thought somebody was gonna so thanks so much for your presentation. I'm a student midwife. I'm literally in a birth center right now cleaning up after birth. I have you like in the birth room and I'm like wiping everything down. No sleep at all. And I got to this path at 42 years old. Like it's the perfect thing to go. It's like for me as a community health worker and just a person who's in community, like this feels like the thing I want to do when I'm an old woman. And I just really appreciate it. I didn't have a question, I had more of a comment. I'm also a reproductive anthropologist, and I started in this field doing research, and then the midwives like snatched me up, and then here I am, all up all night at births. But so much of the presentations that I've seen on Black midwifery are just about the past. And there's always this question of what makes a traditional midwife? Why are you in midwifery? Why are you in midwifery? And we're supposed to have this almost like magical answer. And of course, I didn't choose this. My ancestors basically like snatched me up, and this is why I'm doing this. But we are having to create it over and over again in a new context, under new systems of oppression, and with a big disconnection from our past. And so for me, seeing a presentation like this is like, yes, this is the now. You're actually talking about what's happening now and what makes a community midwife. And I just hope that you do your presentations at, National Black Midwifery Alliance, at the NARM, like go on the route with the student midwives, because the burnout rate is incredibly high for the CPM routes, especially with Black midwives. And a lot of times it's easy to lose your way along the journey, because it's not like this. There's a lot of trauma, there's a lot of problems, there's a lot of difficulty, and also the models that we're being taught, because there's so few Black preceptors and Black community midwives for us to work with who work in Black communities. We often have to go outside of our communities and then have to learn without a lot of guidance how to be in community and do the things that you're saying. So this was just so inspiring. I'm just so grateful for this work. It's so important. And I just look forward to reading all the papers and all the things that come out. And I'm in Baltimore, so.
You are. I absolutely have to meet you. Please give her my email because I want to talk to you.
Okay. Yes. But we'll reconnect. Yeah.
Absolutely. I mean, I think you are so, 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 so right. And that is why, I could have done another study, because I told my funders I was going to do medical racism, and look, I'm like history, and I'm like, yeah, other people are more skilled at me at that. And what my area, to be honest with you, I feel is leadership and the future. And so why not bring that to an important challenge? And one of the things I want to do in the next phase of the week, so I'm going to be on the circuit, so please let me know where I should, if you have advice for me, let me know where I should be going. One of the things we're going to be doing is people were very generous. They gave us their audio. So we have a lot of audio. We have hundreds of hours of interviews, and we're really looking to attract students, master's theses, PhD students to our work. I mean, and to be able to, because this work needs to get out. No matter even if I spend 24 hours a day, me and my team, we just cannot. We just have a lot of that information. But we are producing a podcast, which is a portrait of a birth focused on community birth. And we want to do that later on this year. So this is really important work. And I think for me, the next phase of this work is really looking at the supplies. So a lot of people look at the supply side, like student midwifery training, but the demand side, which is, do women want, really getting women to understand what's at stake, what pregnancy is, what's at stake in pregnancy, and the kind of care they need, and where they can get that kind of care. Like that, I think is the next. That I think is where I want to be spending the rest. Like you want to be an old lady doing that, being in birth centers. I want to be an old lady talking to younger people, really helping, because I didn't have that. I was 33 when I had my child at Johns Hopkins because I was a postdoc there, and I had a C-section. I never had the opportunity to have a vaginal birth, to have a normal birth. And there was no reason, medically, there was no reason that I shouldn't.
Well, thank you so much, Mika and I, for your wonderful comment and question pose. And thank you for your responses, Dr. Felix. And I know we're running out of time, so we have about 2 more minutes. But we do have another question in the chat. Deshonda, don't think that I didn't see your question. I'm going to allow Dr. Felix to email you her response back if you guys are comfortable with that, just to keep us on time with closing. And I also launched the Zoom poll in the chat as well. So if you all that are in attendance could please take the time, just a few quick 2 to 3 minutes to fill out the poll before we end, that would be really, really grateful. And I just want to say my thank yous again to everyone that's able to join this presentation with us. And thank you, Dr. Felix, for a wonderful presentation on current information and giving us insights on what's actually going on. So thank you again. And let me get
Zaire, I'm sorry. Is your name Zaire?
Zaire, yes.
Zaire. Zaire, feel free, like if people wanted my email, happy to.
Okay.
That's the best part of my
Yes.
work, is talking to people in the field or students. I love that.
Perfect. And thank you, Deshonda. I'm getting your email out of the chat now, so I will connect you and Dr. Felix together, okay? Yes, Nevaeh, I'll send you her email so that everybody has her information. So
Yes.
Thank you all again for taking the time to join our speaker series, and please look out for the next one. We'll be in touch. Thank you.
Bye-bye. Thanks.